All right, welcome to the grand finale of Anatomy and Physiology, summer 2025. We're going to start with the respiratory system. I will start by shamelessly plugging the fact that I think this is a really good chapter. I don't always say that, but I think this is a really good read. And my advice to you is to maybe chop it into chunks because there's a whole bunch of anatomy, which I always think is good to do first. It's actually how I'm going to lecture, is go through the anatomy first. And then the physiology makes more sense once you can layer the function into all the structures that you recognize. So let's kind of start with a global perspective here. And that is that your respiratory system does a lot more than just gas exchange. I mean, I think that's sort of the elementary sort of understanding. Yes, you're going to breathe oxygen in, expire carbon dioxide out. Yeah, that's important. But we'll also see regulation of pH. pH is like the acidity or the alkalinity in your body, and it is one of the few things that you have multiple organ systems help monitor to maintain homeostasis. So your entire pH balance is not completely taken care of by the respiratory system, but it plays a big role here. Smell, I'm going to throw this one in because I love like sensation. And smell is so cool. Like you can actually identify stuff in the air. Protection, you're going to have a lot of really wet, sticky tissue in the air that is inhaled either through your mouth or through your nose. You kind of have two different snorkels there. It's gonna get humidified, it's gonna get really moist, it's gonna get any pollen or particulates, like even pathogens could hopefully stick to that kind of mucousy layer and kind of make sure everything is protected so it doesn't get down into the lungs. We'll talk about sound production here. Your vocal cords are part of this system, but I will say the resonation of your voice kind of happens in lots of different places, not just in your larynx. And excretion, as you know, on a cold, dry day, like when you exhale, it's going to be full of moisture and it's definitely superheated body temperature. And you want to take that into consideration in terms of a loss of water and heat when we balance up those systems. In terms of the process of gas exchange, we're going to break it into a couple of key categories. And I will just say that some of these things are pretty obvious. Like there's going to be a mechanical process of breathing, and you should know this, right? You inhale and you exhale all the time. That is technically called pulmonary ventilation. And one of our jobs is going to be to go through the physics of that so that we can actually mathematically show how air flows in one direction and then the other direction. But if you kind of go back to the obvious, like, oh, you breathe air in, you inspire, you breathe air out, you expire, you should be okay. External respiration is the exchange of gases between basically the atmosphere and your blood. So you're taking air from the outside, you're transporting it through a whole bunch of tubes until it gets into the lungs, and then it's crossing into basically the blood. So that's one level. We also have the level where the blood has circulated to the tissue and it's going through the arteries, arterioles, and capillaries. And by the time it's actually moving out of the blood, it's going to basically exchange with the interstitial fluid. That is internal respiration. And these are just kind of like, I don't know, semantic vocabulary words, but external, you're exchanging gases with the external world. Internal respiration is you're basically getting the exchange across a capillary membrane. We also have cellular respiration, and this will be a topic all by itself. And this is indeed the Krebs cycle, but I actually guarantee you're going to love it this time because it will play a role in where the carbon dioxide comes from, which is actually when your body processes sugar. It like basically breaks it into individual carbon dioxides, and it actually requires the oxygen. So while this is a really kind of important piece, like why have you transported all these gases? That will be a topic a little bit later after we get the sugar in our system, which is the digestive system. In terms of the structures of the respiratory system, we can kind of categorize them in a couple of different ways. The first way you're going to see it is just upper respiratory versus lower respiratory. And the cutoff point is actually your vocal area. So, like your larynx, your voice box is kind of in the center of your throat. Like when you put your hand over your throat and you swallow, you can actually feel the cartilage of that structure kind of move up and down. So, everything above that is upper respiratory. And there's actually quite a bit of anatomy. There's going to be nose structures, cartilages, shapers. There's going to be different parts of your throat or your pharynx. There's going to be tonsils, uvulas, all sorts of really cool stuff. But the lower respiratory system is everything from that larynx down. So your larynx is the technical term for your voice box. You should call it the larynx. The trachea, which is just kind of a long snorkel. And then we're going to start to see splits of tubes getting smaller and smaller into the very, very microscopic tissue of the lungs. So lower respiratory, I often hear this in terms of infections, like an upper respiratory infection versus a lower respiratory infection. And one of the things you should know about the lower respiratory system is your lungs are quite vulnerable. So because this is kind of the key area of gas exchange, and it's pretty delicate because it has to get really thin for gas exchange to be optimal, lower respiratory system infections tend to be like a gradient of magnitude worse than upper respiratory infections. Those tend to be like sore throat, runny nose, something like that. All right, here's a cool picture of a guy with really teeny tiny lungs. I think it's, well, maybe it's unisex. I don't know. Hard to tell. You can see kind of the head and sagittal section here. There's quite a bit of space in the nasal cavity. We're going to kind of review some of the skull structures there, the nasal conchae, the turbinate bones, which kind of create like a swirling of the air. You do have the ability to breathe in through your mouth too. Your nose, by the way, is the way to keep breathing when you're chewing your food. And, you know, you have to do that. So you kind of need a secondary like airway there. And then we'll see those two kind of converge into a single pharynx, which is the back of your throat. And from there, we need to kind of have a split between the digestive tubes and the air tubes. The digestive tubes, like the esophagus, are going to go back. They're actually posterior to the airways. And you can kind of see here, there's cartilage reinforcing a single long trachea that's going to split into right and left into the lungs. And it's also kind of neat to note that the human lungs are asymmetric. We have 3 lobes on the right and 2 lobes on the left. Part of that is how it develops and the fact that the heart is kind of skewed towards the left, and there's actually a big notch carved out of the left lung for that. But you know, you're talking about the thoracic cavity, so we'll have like the pleural membranes and of course the diaphragm, which is actually physically attached to kind of the outer wrapper of the lungs. In terms of functional divisions, which is another way that we could categorize the respiratory structures, we could look at their function and say, well, there is a conductive portion, and this is basically just plumbing. This is like tubes. Those tubes could be thick, they could be thin, but there's no gas exchange happening here. This is really just a transportation network, and this is the majority of the structures. We're going to have the nose, the back of the mouth, the larynx, the trachea, the bronchi, which are the big tubes, the bronchioles, which are the really kind of small 1 millimeter or smaller tubes, the last of the little tubes, which are the terminal bronchioles, but that is now getting pretty small, even microscopic. Then we can start talking about the respiratory portion. And the structure that will allow gas exchange in the respiratory system is a very small, microscopic, thin structure called an alveolus. So alveoli are plural, and you do have millions and millions and millions of alveoli, but these little delicate air sacs are so thin, this is actually where we can get gas exchange. And I just kind of want to point one thing out. Most of these, like, airway, like gas exchanging alveoli are alveoli, but there are occasionally like a handful of alveoli that may be located on the very end of a bronchiole, which technically should be in the functional division that is conducting only. I totally get that, but a respiratory bronchiole is a bronchiole with just an alveolus sticking off of it. And histologically, it's good to kind of watch out for those. It's just a little bit of a gray area between the conducting and the respiratory portion. But because gas exchange is happening there, it really needs to be considered the very earliest possible respiratory zone. In terms of volume comparisons, your lung capacity is actually quite big. Like you have lots of alveoli that can have potentially lots of liters of gas moving through them at the max. 5 to 6 liters, it's a little closer to 6 for males, a little bit closer to 5 for smaller people. The conducting portion is about 150 mils. And one of the important things about the respiratory zone is that we measure how much air is flowing through a person's lungs. It can tell you all sorts of different pathologies. But just keep in mind, the majority of the real estate is actually a respiratory portion in terms of its functional division. If you love this stuff, you might consider ear, nose, and throat medicine. They actually do some cool stuff sometimes, like if you need to get your tonsils out, like it's pretty obvious going on there. Pulmonology is actually really cool too. It's like lung specialists. And if you have a chronic lung disease, like, I don't know, emphysema, asthma, whatever, the pulmonologists kind of really focus on just the lungs. Okay, let's kind of go through some of this anatomy here, starting with your nose. Your nose functionally is really going to provide like a space for the air to get swirled around, and that creates a warming effect. It also humidifies and kind of wets the air so that it's not super dry. We want to make sure that all of the air that reaches the lungs is not only body temperature but 100% saturated with moisture, because you don't want any of those little alveoli to dry out. Of course, this is where you're going to have smell reception in that superior portion of the nasal cavity where the olfactory epithelium is. And your nose does play a role as a resonating chamber. It's just like some extra hollow space so that your voice like sounds, I don't know, cooler. Anyway, you can kind of see the reinforced cartilage in the nose. It kind of creates two little snorkel holes. Of course, this all has anatomical names, but you know, everybody knows where their nose is. There's going to be some bone and extensions off of that bone, which is the perpendicular plate, right, of the ethmoid bone and the vomer. That extension that you can kind of wiggle a little bit on the end of your nose is hyaline cartilage. Like it's a pretty firm cartilage. It kind of keeps it, you know, in place. There's going to be skin, mucous membrane. Of course, like mucous membrane is going to produce mucus to kind of, I don't know, intercept anything that you inhale. And your little nostrils are actually called external nares. I will say nare is a Latin word. It means narrowing. There are some nares on the outside of your body, like these are external nares. There's also internal nares, kind of where you see a narrowing and the airflow kind of gets restricted a little bit. So don't think of nares as just your outer nostrils. I mean, they are, but there's other narrowings other places. Internal nose structures, we've got the nasal cavity. It's actually a pretty big cavity. I don't know if you guys have had any COVID testing. The brain pics, it goes way back. I'll remind you that the nasal septum is the wall between the anterior chambers of the nasal cavity, so it's got kind of a separation on the right and the left hemispheres. Everything in the front of the bone is just cartilage. Next, about the nasal cavity, we will see that it extends from your outer nostrils, your external nares, to some internal narrowings. And this is going to be at the very, very posterior aspect of the nasal cavity. And like I said, it's actually pretty big. And it just kind of pinches together before entering the back of the throat. So what's interesting, I think, about the nasal cavity in respect to the rest of the respiratory system is it has a different type of histology. So where you have stratified squamous epithelium, that's where you expect the most friction. Where you see respiratory epithelium is where you don't expect friction. And friction could either come from, you know, putting something into your nose nose, like your finger, or maybe in the back of your throat, like where you're chewing and stuff, that would be like needing some kind of friction-proof epithelium. Where you have exclusively airflow, it is what we actually call respiratory epithelium, which is pseudostratified ciliated columnar epithelium, highly vascular because we want to have lots of blood flow there to keep it nice and warm and wet. And there's also copious unicellular goblet cells, which produce the mucus. So think of your nasal cavity as having slightly different areas of histology based on what it's going to be encountering. If it's going to be at the very far front or in the back, it's going to have a different type of mechanical trauma, basically. But where it's just airflow, it would be respiratory. And if you've ever shot like milk out of your nose, you know it burns, right? That is the sensation of having mechanical trauma on respiratory epithelium, and you can probably feel exactly where that's going to be. We've also got the drainage for our tear ducts. So remember, the nasolacrimal duct collects all of the tear fluid that washes over the front of the eye, and it kind of drains into the back of your throat. That's the nasolacrimal canal. We also have some openings to the paranasal sinuses, and sinuses again are just pockets of space to kind of hollow out the skull a little bit so it's not quite so heavy and dense. And of course, those sinuses are going to potentially be a infectious opportunity for different types of pathogens that can certainly colonize the upper respiratory system. If you've ever had a sinus infection, it's very annoying. In terms of functions, like I said, the nasal cavity is just like a secondary airway for when you are chewing, which is good. Like, you want to chew your food. We don't have the easiest time with digestion unless it's kind of partially like masticated or chopped up. It also cleans the air by sticking any pathogens to the mucus. Hopefully it gets most of it, almost all of it usually, unless your air is really super dirty or smoky. And of course, the humidification and that warming of the air so it doesn't actually freeze the lungs. My mother's father, who died before I was born, he lived in Alaska. He's kind of like a very outdoorsy dude, and he had frostbite in his lungs. And it was because the air was so cold. Like, when air is really, really cold and it kind of like freezes things like on contact, it can actually not have time to get humidified and warmed by the time it goes down into your lungs. It kind of just like freeze dries your lungs. It's actually really awful. I think he died a pretty horrible death. Anywho, let's take a look at a sagittal head here. You can kind of see the nasal cavity above the hard palate. The hard palate is the roof of your mouth. And I will say everything above the hard palate to the top of the, nasal cavity where your ethmoid and frontal bone would be is the nasal cavity. So you can kind of see how far back it goes. And that narrowing there between the sphenoid bone, do you see the little sella turcica there? And the very pinch between that last little bit of the hard palate and the soft palate? That's the internal nares, and that's basically the very end of your nasal cavity. Beyond that, it's actually the throat. There's three parts of your pharynx or your throat, and the nasopharynx is the topmost portion. And then you've got the oropharynx, which is kind of where you swallow things back into. And then you've got the laryngopharynx closer to where you have the voice box. So I did want to point out those nasal conchae. You can see that there are three. We were only ever able to visualize two on the skull through the nasal cavity when you kind of look through the face of a skull. But you can see that there's kind of those three lumpy, wavy, swirly bones that kind of create like a little wind tunnel. Those are the nasal meatuses that are part of those nasal conchae, which kind of, again, are on the lateral surface of your nasal cavity. Speaking of the pharynx, I want you to think about it as a funnel, and it really is oriented away to kind of direct food down the throat into the esophagus. And what's interesting about the pharynx is that, I mean, not only that we have three regions, but what we have is like a different degree of control over swallowing at different parts of the pharynx. The top of the pharynx, you have absolute 100% voluntary control over what you put down there. So as you start to swallow, your command is like in your voluntary brain, you're thinking about swallowing, you're swallowing, but then it actually transitions to smooth muscle, and it kind of is more of a reflex, and you can't really do anything about it. There's a point of no return. You've gone too far back, and now it's basically just going to be an autonomic swallow. And we will see that that transitions out of skeletal muscle into smooth muscle, which is kind of cool. All you have to do is kind of think about it. There's a few functions of the pharynx that I'll kind of mention in addition to swallowing. It is a sound chamber. You need that space, that open space, to kind of get the sound production resonated so that you can generate a loud enough sound to speak. And then, of course, you've got some tonsils. So here's a picture from your book which kind of beautifully rainbow ombres the three regions of the pharynx. The greenish area that's kind of in the very, very back or posterior aspect of the nasal cavity is the nasopharynx. So kind of where the big open cavity is the nasal cavity. And you can see it gets kind of narrow, the internal nares, right before it turns green. That means we're now in sort of a respiratory exclusive zone. The nasopharynx is kind of just that top, I don't know, inch or so. And then as it's transitioning to the back of the oral cavity, like if you can imagine putting some food directly back into your mouth and then into the back of your throat, that would be the oropharynx. And that is going to have a dual purpose. It's going to be for air and for food. And then we're going to see as you swallow, we will hopefully cover the airway with the epiglottis and then direct all the food, solids, and liquids down behind into the esophagus. So does that fail sometimes? Yes, it does. Sometimes you kind of get things down the wrong pipe, so to speak. But what's very interesting to me about human voice boxes is ours is so high up in the neck. When you compare the anatomy of a human throat to, like, I don't know, a sheep or a pig or something, our larynx is positioned quite high. I mean, it's almost at the base of the skull. And that really does present a choking hazard. People choke all the time. But animals tend not to do that because their whole apparatus is lower. But I will say the advantage of having your larynx so high in the throat, close to your resonating chambers in your skull, like your oral cavity and your nasal cavity and stuff, is that we can actually produce a very wide range of sound. So I guess a benefit is you can like articulate. I'm joking, but it is kind of a trade-off that I've always found kind of fascinating. All right, let's start with the special stuff of the nasopharynx. This is going to be everything from that back of the nasal cavity, the internal nares, down to the uvula, which is kind of that little punching bag in the very back of your throat hanging off of your soft palate. There are 5 tonsils in your upper respiratory system. There's kind of 2 up high that people usually refer to as adenoids, and you could refer to them as adenoids. That's cool. But I don't want you to think that they're anything other than tonsils. They're just your top 2 tonsils. You have the auditory tube or the eustachian tube from the middle ear. Like, you remember that from 232? Kind of that little air, like, equalization tube so that you can keep no pressure on your tympanic membrane. That will be located in the nasopharynx, the opening of it at least. This is air only. So, like I said, if you've ever had something shoot out of your nose that shouldn't, it kind of burns because this type of epithelium is not very fortified for that kind of mechanical damage. So it kind of creates that little burn. That's the respiratory epithelium, the pseudostratified ciliated columnar. And of course, this is going to transition into the back of your mouth, your oropharynx. So if you just shot a laser beam into the back of your throat, it would basically hit the back of your oropharynx. It's really just between the soft palate and the epiglottis. So remember that epiglottis is the little flap that's going to cover your airway when you swallow food or drink liquid. This is kind of a dual purpose, it's just kind of going to move things from your throat downward and hopefully will separate things appropriately. We will also see another set of tonsils. There are palatine tonsils. And if you've ever had to stick out your tongue and say, basically what you're doing is pushing those palatine tonsils forward so that, a doctor or someone can take a look at them. We like to swab those in micro before social distancing ruined everything. The lingual tonsil, the fifth tonsil, and it's a single tonsil, is at the base of the tongue. So if you've ever had like anybody in your life with a tonsillectomy and maybe even adenoids and tonsillectomy, kind of removal of those, you still have the lingual tonsil. So like a lot of people don't ever, I don't know, remember that one, but I kind of like it. It's the base of the tongue. It kind of makes the tongue look lumpy in the back. The laryngopharynx is going to basically be a very complicated portion of cartilages and different tissues that all serve to protect the vocal cords. So this is going to be from the epiglottis or the hyoid bone. Remember the hyoid bone is buried inside a lot of soft tissue. You usually don't see it unless you're cutting it open. To the very inferior or bottom portion of the voice box, which is a cartilage known as the cricoid cartilage. Cricoid means circular, and it's the first kind of circle of like a ring of cartilage that we see at the top of the trachea, basically. Let's take a look. You can see the hyoid bone here on the top anterior view. Remember that kind of looks like it's got little fangs like sticking out of the the top surface of it. That little red tongue looking thing is actually the epiglottis. You can see from the lower right lateral view, it kind of looks like a little flap there. But what I'll point out first is that you have a whole bunch of cartilages. Some are bigger, some are smaller, some go all the way around, some don't. But the first one you'll notice is the thyroid cartilage. And this is actually where your thyroid gland is attached to. Remember from 231, thyroid cartilage, thyroid means shield shaped. So thyroid is just a generic term, and you can see that that cartilage is going to shield everything that is under it pretty securely. Like you don't want to crush that cartilage because your vocal cords are going to be under there. Now there's another kind of like lower cartilage you can see underneath the thyroid called the cricoid cartilage. Notice that this one goes all the way around. When you look at the lower picture, the cricoid is actually enlarged in the back. So it's a ring, but it's actually really pretty tall in that very posterior aspect of it. Kind of just creates a nice circular support structure. Now, there are other things in here that I'll mention. There's going to be some hinges that are sticking off of the posterior cricoid cartilage, the arytenoid, corniculate, and cuneiforms. There's two of each of those, one on each side. Those are basically going to swing around as you vibrate your vocal cords. So you can kind of see on this like sagittal view here on the bottom, there's kind of this white ribbon and it kind of has a little pink in the center. There's kind of these two folds, vestibular, which are your false vocal folds, and then the true vocal cords are your vocal folds, and those are always underneath the vestibular fold. The vestibular fold is protective, and if you just hold your breath for a second and you can feel where you create an airtight seal, the vestibular fold is what actually comes together to produce that seal, which is kind of interesting. And I'll just kind of remind you how amazing your vocal capacity is now that you know things about sound from 232. You know that these vocal folds can vibrate thousands of times per second. So those extra cartilages, the arytenoid, the corniculate, and cuneiforms are also going to kind of vibrate or move like astonishingly fast. Anyway, this is the laryngopharynx, also known as the larynx, right? Which is basically all of the things you need for your voice like to come out. I would prefer that you call this the larynx and not the voice box. I don't know, it just sounds cooler. And I do want you to keep track of these cartilages. You have the anterior thyroid cartilage, and under the influence of the androgen testosterone, it does have a little bit of an anterior prominence, which is the Adam's apple. I don't want to give you the impression that this is a separate piece of cartilage that you can sometimes see in the neck of certain folks. It's hypertrophy is basically what I would describe that as. It's just tissue enlargement. The cricoid cartilage is that ring on the bottom, and remember that one goes all the way around and it's kind of a little bit elongated in the back. The arytenoid, cuneiform, and corniculate are paired, and you have basically a right and a left hinge that is constructed from those three cartilage hooks, kind of, and your vocal cords are actually attached to that. The epiglottis is just a single piece of cartilage, and what makes the epiglottis unique is that it is made out of elastic cartilage. The rest are all hyaline cartilage, so they're much firmer, they're just structurally more of a strong protective structure. The epiglottis is elastic cartilage. It makes it a lot more resilient to movement and then recoil back to its original shape. And what I think is weird is that a lot of times you see these pictures of the epiglottis and you think that it's like a little flap that moves up and down. That's not actually how it works. The throat, when you swallow, like feel it, put your hand over your throat and swallow. You can feel everything move up, and what it does is it kind of smashes against the epiglottis as you swallow. The epiglottis doesn't really need to move very much. It just needs to kind of go back into its original position once everything is relaxed. So it is kind of an unusual, like, illustrated kind of structure for me, because it kind of gives you this impression it's like a little spoon that like flops around or something. It's not that. It's like the muscles of the throat close up into the epiglottis, and then hopefully you don't swallow things down the wrong pipe. Here's kind of the bird's eye view if you were going to basically intubate someone. What you're looking for are those vocal cords. They're usually pretty like white ribbonous kind of looking tissue. You just want to make sure you don't nick those because, I mean, it's somebody's voice, people. Anyway, the rest of it is pretty pink and fleshy. Anyway, the other thing is, this is a picture from your book. Do you see how it's labeled tongue at the bottom? This is probably more accurately labeled as the epiglottis, but the tongue would be next. Like it would be kind of the next structure that you'd see. But I think I kind of take a little bit of offense to this picture. I don't know. It's just like nobody's tongue looks like that. It's really long and floppy in your mouth. Okay, I want you to remember the ventricular or the false vocal folds are on top and the true vocal cords are inferior. And I do think that they're kind of noticeably whitish color, if that helps. I don't know. And you want to think about the ventricular or the false folds as being protective. They're kind of there to kind of come together to protect anything from falling into the vocal cords. The trachea is next on my list. It's your windpipe. It's about 12 centimeters in length. It's about an inch in diameter. It's a pretty big snorkel tube, and it goes from the cricoid cartilage to the first branch. The next generation of tubes are going to be called bronchi, but if you just kind of remember the trachea is a single pipe that goes all the way down before it splits, that's where it's still the trachea. We should see similar histology here to respiratory epithelium. There's going to be pseudostratified ciliated columnar goblet cells. It's pretty fibrous because it has to kind of stretch and recoil a little bit. There are some glands that we might see in the deeper submucosa, just kind of the deeper connective tissue layer. But one of the really cool hallmarks of the hyaline cartilage that we see in the trachea is that it is formed in the shape of a C ring. The C keeps it really nice and round, but because it's not a whole circle of cartilage. There's a muscle that actually connects the ends of the C that allows the trachea to dilate and then contract a little bit. So as you are increasing your airflow during like aerobic exercise or something, there's times when you want your airways to dilate and actually be a wider tube to move more air. That is only possible so that that muscle can kind of hold it together as those C's kind of flex a little bit. It's kind of cool. Also, if you're swallowing some big old chunk, you want to give it room. You don't want your trachea to like form like a blockage, right? Like you don't want it to like stall. That's the worst. That could also be a process for making sure that we don't want a full circle of cartilage. Okay, adventitia is just the outer wrapper of this structure, and adventitia just implies it's the outer wrapper, but it's also quite fibrous and it's kind of glued to the surrounding tissue. So I would describe that as loose connective tissue or areolar connective tissue. Remember how areolar has all those fibers everywhere? It just kind of anchors it into the mediastinum and the thoracic cavity. All right, let's take a look at this stuff. I don't know why these lungs look so awful. They look like spleens to me. Anyway, if you just ignore the fact that this is spleen lungs, everything else about this is pretty cool. You can start on the left with the hyoid bone. You can see the thyroid cartilage in the next ring, which is the cricoid. And then we have just a long tube at the very base. That is the trachea, and that is where you would expect to find the C rings of cartilage. Histologically, on the right, we would see pseudostratified. Remember, pseudostratified just makes all of the cells just look packed together so that all the nuclei are just all squished. It's got lots of cilia. We want to kind of trap any sort of pollen or whatever and then move it with that cilia so that we can spit it out or swallow it or whatever. There's some glands. I can see kind of some circular cuboidal glands, and then there's some hyaline cartilage at the very lower left corner of that picture. There's one other thing that was not illustrated. I tried to illustrate it on here for you. Do you see at the very base of the trachea, there's sort of a weird triangular plate of cartilage? I often describe this as in the shape of a pair of underpants. It's obviously hollow on the inside, but there's a big hole on the top, and then it splits into right and left sides. That little underpants pair of underpants cartilage is called the carina. The carina will be an important structure for the trachea because there's a really important cough sensor there, so that if you have unfortunately swallowed something all the way down all of the epiglottis and all the vestibular folds and all that stuff, you'll be able to cough it out if it hits that carina. It's a very violent cough like sensor, but please do not call it underpants. In fact, tell no one that we spoke of this. Anyway, next, what we're going to talk about is the first splits. So we're going to have a right and a left tube. Those first tubes are the primary bronchi, or a single one is a bronchus. I will just have you note that the right bronchus is slightly wider and a little bit more vertical than the left. And I mention this because when people aspirate or choke things into their lungs, it tends to fall into the right side more than the left. And it's not any other reason other than it's just anatomically a little bit easier for things to fall into the right. I will say that there are multiple branches of the bronchi. The first portion of the tube is the primary bronchus. The next branch will be the secondary. The next branch will be the tertiary. The next branch will be the quaternary. And after that, we lose track and we don't even really have to name them. I just want you to know that there are more. First, we've got to bifurcate that trachea into right and left bronchi. Remember that right one is clinically significant. We've got a shift here histologically from C rings to what I would consider plates or islands, like these kind of just like circles of cartilage that look like they're broken up a little bit. The epithelium is remarkably similar. It's still respiratory epithelium. Remember, we've got the carina with that cough reflex. But then we have this primary, secondary, tertiary bronchi. So when you count how many primary, secondary, and tertiary there are, it's actually kind of cool. There's two primary. One goes into the right lung, one goes into the left. There are five secondary. You actually have three lobes of a right lung and two lobes of a left lung. So sometimes we'll actually call those lobar because they match the number of lobes. And then another really cool thing about human lungs is that the lobes are kind of in chunks called segments. And there's a tertiary bronchus for each segment. So here's where we're going to stop naming those branches, but I do care that you know that there's more. As we get smaller and smaller in terms of these conduction tubes, we're going to see a shift from very tall pseudostratified ciliated epithelium to more just regular simple columnar. Like it's going to get thinner, basically. We're also going to thin out the mucus production because it's not helpful as much anymore. The likelihood that we have trapped the pollen or the pathogens is high above this point. If we haven't captured it by now, the mucus is more of a nuisance to us in terms of kind of inhibiting gas exchange by producing just a layer of gunk. So we're going to thin that out. We're going to decrease the goblet cells. There's less mucus, there's less cilia, and we will eventually phase out all of the cartilage. So when we phase out the cartilage, which is just structurally keeping that stuff open, we are going to increase smooth muscle. As you know from other terms, increased smooth muscle means increased control. We can basically open and close certain tubes depending on how the airflow is moving through the lungs. So look out for that. By the time we get microscopic, and I would say that this is pretty microscopic, it's 1 millimeter. I mean, if you've got good eyes, you can see it. But what we discover here is that all of the cartilage is missing in the bronchioles. So one of the interesting histological findings here is the absence of cartilage. It's not the presence of something. It's that there's no more cartilage. It's all phased out. And what we're going to start to see is more smooth muscle. So look for that like layer of circular smooth muscle around these tubes. And as you kind of can infer, my epithelium is also going to get thinner and thinner and thinner until we reach the alveoli, which are going to be simple squamous, the thinnest of all of the epithelia. So bronchioles are microscopic, cartilage-free, smooth muscle encircled tubes that are lined with simple cuboidal epithelium. This is kind of the last little bit, and if you can see that it's attached to alveoli, you'll know that it's a terminal bronchiole, like it's at the end of the line, right? But we want to watch out for respiratory bronchioles. Like I mentioned, there can be an occasional stray alveolus just hanging off one of those bronchioles, which makes it technically respiratory, but it's totally going to terminate in basically a cul-de-sac. If you know what those are, like where someone lives in a dead end and there's like houses all the way around in a circle. It's basically a cul-de-sac of alveoli, and that's the last stop before we get gas exchange. Check out how vascular these are. There's so many capillaries around the alveoli. I mean, this is really important that we get this exchange, like this external respiration of the air that has made it all the way to this point into the blood inside those capillaries. All right, now we are microscopic. I gotta tell you, so alveoli is just a cup. We've actually seen this term before with tooth sockets. Remember? Blast from the past. You've got a whole bunch of alveoli because, you know, you breathe crap and some of them are going to get damaged. That's just going to happen with life, right? A sac by definition is just multiple alveoli, and like you can get kind of this little duct, which is still just simple squamous epithelium, but just like kind of transitions into a dead end. And then we have that respiratory membrane. And this is 0.5 microns. I might remind you that the diameter of a red blood cell is 8 microns. This is one of the thinnest divisions between the outside world and your inside world, and this has to be thin and optimized for diffusion of gases. So all we really see here is the alveolar squamous epithelium. It teeny tiny bit of connective tissue, the basement membrane, and then the simple squamous endothelium of a capillary. I do kind of want you to remember that type 1 is for gas exchange, and I just remember the number one function of the lungs is gas exchange. That's never let me down. Type 2, which do tend to be a little fluffier, like they're just not quite as flat, those are the surfactant cells, and again, that just kind of reduces surface tension and makes sure that those alveoli don't collapse just from the water inside them, kind of crushing it from the inside. And then you should absolutely look for alveolar macrophages. If you're super old school like me, we used to actually call alveolar macrophages dust cells. I kind of like that term though, because it kind of tells you what they do. They go around and eat dirt. Next, I just want you to know there's lots of branches. So we started with the trachea, primary bronchus, secondary bronchus, tertiary bronchus, quaternary. I don't know the name for the fifth one, sorry, but it goes fifth, sixth, seventh, eighth. There's so many generations of branches. Like, this is a super branchy structure. But finally, we get to talk about the lungs. So remember, the lungs are sitting inside the thoracic cavity, and we have that double set of membranes, the visceral and the parietal pleura. Now, visceral is always the organ, so it's always on the inside layer, and parietal, like the parietal bones of the skull, kind of around the outside. So that's going to just be the wall of the thoracic cavity. So we have the outer surface of the lungs, the visceral pleura, and then the chest cavity itself, which is the parietal pleura, which is a little space and a little bit of fluid in between those two layers. And for this, I really want you to know that this pleural fluid is a vacuum, and it keeps those lung surfaces stuck to the thoracic cavity. They can move, they can slide against one another, but they shouldn't separate because there's actually a vacuum pressure inside that space. Fluid, of course, is going to reduce friction, but that pleural cavity is going to be a really important phenomenon when we talk about how ventilation works. One of the things you haven't seen is any muscles of the lungs, right? I mean, there's a little smooth muscle around tubes, but there's no skeletal muscle for breathing. All of the breathing muscles are happening outside of the pleural cavity. So the only way that the ventilation is going to work is if, as you move your chest, the surface of the lungs sticks to the chest cavity, and it has to be under pressure. In terms of overall lung architecture, we have, I don't know, is it kind of triangular? I don't know, not super, but it does have a point at the tip. The superior aspect is the apex. The base is kind of the bottom, and that's actually going to be glued to the diaphragm too. So the same kind of curvature of your diaphragm is the same kind of shape as the base of the lungs. Now, the hilus, this is kind of a really cool old Grey's Anatomy picture. This is basically the medial portion of the lungs. So it's kind of, you're looking at it from a weird angle. This is basically where all the arteries and the veins are going to go in and out from the heart. And you could call that the hilus. You've seen the term hilus with like lymph nodes and spleen. It just means the medially indented portion. It's kind of curved usually. The root is basically implying that this is where the vessels are coming in and out. And I think those terms are pretty interchangeable. I'll also just kind of mention that these lungs that we have are asymmetric one more time. We've got 3 lobes on the right, 2 lobes on the left. Those lobes are separated by fissures, very deep cracks with a little bit of connective tissue in there. And those fissures are actually named just for their orientation. So there's a horizontal fissure that separates the superior right lobe from kind of the middle. And then we have a more of a diagonal or an oblique fissure that separates the middle from the inferior lobe. That's your right lung. On the left side, you've got 2 lobes, just a superior and an inferior lobe, and then it just has 1 oblique fissure. But what's kind of cool about the left lung is got a little scoop for the heart, which I think is pretty obviously going to fit in that space.